hears me okay? Kind of, sort of. Okay. Yeah.
Then just click off of the Zoom.
All right. So, hi, my name is Valesky. If you guys have been around here for a while, you obviously know who I am. For some of the new people, I am one of the ER attendings, and my current fellowship is stroke. So we're going to move on from there. So anyway, basically what we've done is that we've seen a little bit of issues with stroke codes at the downstate ER and the Kings County ER. And what we wanted to do was, I remember when I was a resident, I didn't have a huge amount of a clue in terms of kind of what I was doing. I had kind of a basic background of how to manage stroke, but I think that there's certain nuances that I think that we probably haven't kept up to date with. Some have, some haven't. And so I wanted to give kind of an overall format or an overall approach to how you end up basically managing a stroke code. Obviously, as frontliners, we're going to be the first ones to see this, and this is basically where us being at the bedside, seeing the patient, and understanding the literature is going to help us to a great deal. So in regards to the outline of this, basically I wanted to talk a little bit about our New York State Department of Health Stroke Designation Program, and then I wanted to get into the approaches in regards to dealing with the stroke code. In particular, dealing with stroke mimics, severity scales, CT findings, thrombolytics, and thrombectomies, because that's pretty much your branch points in regards to managing a stroke code in 2020. Now, the technology has been changing essentially over the last 5 to 10 years pretty dramatically in terms of what we are doing right now for stroke codes. There's probably going to be a lot of technology changing as well. One of the biggest things that we've done so far, though, is we've kind of shifted from using time as an indication of ischemia and infarction to looking at collaterals and perfusion radiographically. And so that's been the biggest change that we've had over the last 5 to 10 years. And I think it's important to understand that, because time is not really a great marker of perfusion, but it's the best thing that we've had over the last 5 to 10 to 20 years. And so we're beginning to move away from that. And right now, we're actually kind of in a little bit of a gray area, where we're partially using that, but it's very, very possible that in the future we are going to shift away purely to perfusion and collateral-based evaluation of these patients and whether or not they should be getting thrombolytics, thrombectomies, and so forth. So without ado, we'll kind of get started. So in New York State, there are 3 different kinds of stroke centers. There's comprehensive thrombectomy-capable and a primary stroke center. So in regards to in Brooklyn, this is essentially what we have. We have 2 comprehensive stroke centers. They are Maimonides and they are NYU Brooklyn. In regards to the other hospitals that we manage at, I was just informed loudly by the stroke director at Kings County that we have shifted from a primary stroke center to a thrombectomy-capable stroke center at Kings County Hospital. SUNY Downstate is a primary stroke center. And so one of the big things is, what does all that mean? In regards to a comprehensive stroke center, essentially this is the standard. So this basically is the Lexus of stroke centers, and you'll realize it when you basically go into them. And essentially they are in charge of developing basically our higher grade stroke care. So they do have certain requirements as a result of being named this. So those requirements are to be able to perform 15 thrombectomies averaged over a couple of years. They have to provide subarachnoid hemorrhage care to a certain number of patients per year. They also have to end up performing a certain amount of coiling and or clipping to aneurysmal patients. Additionally, they have requirements over the number of IV thrombolytics that they are given per year in regards to a minimum. And then they have to end up having an on-call cerebrovascular neurosurgeon and a vascular neurologist. And then obviously a neurologist needs to be available within about 15 minutes. And so usually that's going to be in the form of a residency program or a PA and a nurse practitioner who's responding to stroke codes. A thrombectomy-capable stroke center is just that. It's a stroke center that does thrombectomies. It's essentially a primary stroke center where you end up having an interventional neuroradiologist who's on call, who has the ability to perform mechanical thrombectomies. It's that and nothing more. There's no requirements in regards to having a neurosurgeon on call, no requirements in regards to dealing with aneurysmal patients or subarachnoid patients. However, In regards to essentially our new kind of standard of moving ahead with stroke care, this is becoming a priority, and you're going to see why when we kind of discuss EMS protocols in regards to triage. Kings County is a thrombectomy-capable stroke center. A primary stroke center is essentially us here at SUNY Downstate. Essentially, there's no requirements for a vascular neurologist, and typically there has to be a transfer agreement in place with a comprehensive stroke center. In our situation, that stroke center is Maimonides, but however, you do have the option of transferring these patients to anywhere you choose to. However, typically time is going to be of the essence. So we try to get these patients to the quickest location possible. The reason why we've chosen Maimonides is that essentially there is a situation in place where they are the same academic department. They have the same chair and they have the same residency program. And so that's the reason typically why we choose MIMO, but it's not mandated that if you did have a thrombectomy case, you would have to transfer it to Maimonides. However, just for ease, that's basically the same place. So if you've been working with the stroke team, or essentially if you've dealt with the stroke team in a capacity in the emergency department, I'm sure you've probably been asked to perform some of these measures. You've probably been asked about doing a dysphagia screening. You've probably been asked about what their NIH stroke scale score. You've probably been asked other questions as well too. The rationale for this is that these are performance measures mandated by the state. So you are required to perform these to keep your status. So when we basically are asking dysphagia screening and so on and so forth, these are mandated measures by the state institution. And so whether or not they're based in evidence or not, most of them are, but there are certain mandated requirements that we do have. And this is some of the rationale for some of the things why we do. Some of the more pertinent measures to you working in the emergency department are a few different things. And so you've probably recognized these in regards to kind of some of the procedures that we do, either in SUNY Downstate or Kings County. An MD must assess a patient as they walk through the door within 10 minutes. The stroke team must assess them within 15 minutes. One of the bigger things is a door to CT time. Typically that must be completed within 25 minutes. You've probably, if you've worked for a period of time over here, you've probably seen the setup over at Kings County where we don't end up taking our patients initially to get evaluated in the emergency department. We take them to a special triage area. Some authors recognize this as a launch pad or a stroke assessment area, and we take them through there so they can proceed directly to CT time. This is to basically streamline the process, streamline the flow so we can prevent delays, such as obtaining EKGs, such as obtaining IV access, such as obtaining labs. Most of these patients do not require this before they go to a CAT scan. That shouldn't be, you shouldn't basically kind of gloss over this if you have a medically unstable patient or somebody with respiratory distress. But if the patient looks well and comfortable otherwise, and essentially their finger stick is normal, these patients should go directly to the CT scanner. There's also imaging times in terms of your read time, and then there's also requirements in regards to giving TPA. Essentially 85% of your patients should get TPA within 60 minutes. And they're also, as in regards to our basically third round of Get With The Guidelines, essentially we're trying to give door to TPA within 45 minutes, and that's supposed to be about 50% of our patients. So you can see the onus is on speed and on efficiency when we deal with these patients. So that was just kind of a little bit of a breakdown in regards to basically kind of what we're dealing with in terms of flow and essentially the setup. Now I just kind of like to go through approach. So I was going through a textbook called Osborne Neuroradiology, fascinating reading. And essentially this is, and so the point of saying that is that this is more of a radiographic question, but I think it can be applied to most strokes. Essentially you should be thinking about approximately 4 different questions. Excuse me. So is there, and I think this should give you kind of a framework for approaching your stroke code right now in the year 2020. So number 1, is there an intracranial hemorrhage or a stroke? Something that essentially looks like a stroke, but it's not a stroke. Is there a large vessel occluded? Obviously, that's the rationale for some of our endovascular treatments. Is the brain irreversibly injured? Because that would negate some of our treatments. And is there an ischemic penumbra present, which obviously would basically warrant us to proceed with some of these treatments, most notably endovascular therapy after 6 hours and up to 24 hours, which we'll discuss in a few moments. So going to stroke mimics, I'm only going to basically kind of give a few that I think that you probably should know. Hypoglycemia, everybody knows that, and we'll kind of go through that, but also migraine, seizures, and functional disorders. This graph is from a retrospective review looking at about 512 patients or so, and you see there's a lot of seizures and there's a lot of migraines that present stroke mimics. So in regards to hypoglycemia, I know this is pretty obvious and I don't want to harp on it too much, but I do want to basically make sure that it's understood that the majority of times when you end up taking care of a hypoglycemic patient, you will end up visualizing non-focal neurologic deficits. Patients may have altered mental status, they may appear confused, they may appear a little bit agitated and tachycardic, diaphoretic, so on and so forth. However, not all patients who end up having hypoglycemia will end up having non-focal deficits. Some will have very, very focal deficits. And there is a situation in the literature, sometimes people refer to it as hypoglycemic hemiparesis, other times people will just refer to it as a focal hypoglycemic episode. The idea is that these things will look very, very much like strokes. So just remember, it's not always going to be altered mental status and confusion as your classical presentation of these stroke patients. Some of these mechanisms are going to be vasospasm, changes in autoregulation, issues with the NMDA receptor, but I'm not going to kind of go into that. It's just basically so we understand that there is this possibility and basically just to harp on it to make sure that it gets done. In some situations, this hemiparetic hypoglycemia can actually end up causing changes on MRI. If you see basically kind of over here, this image, you see basically you see an issue in the posterior capsule, the posterior limb of the internal capsule, and here you see the correlate on the ABC. These changes can be seen on the MRI, and most of the time they can be reversed when giving glucose. The next thing that I wanted to get into was seizure at presentation, because I feel like this may not be necessarily understood as well as it should be. In the initial NIHSS trial, seizures were a contraindication to giving thrombolytics. They were considered an absolute at one point in time. At this point in time, in 2019, as per the most recent guidelines, they are not absolute contraindications. They're given level 2B evidence. Now, I'm not saying that that means that you should give thrombolytics to everyone, but you should be kind of assessing and weighing the risks and the benefits of giving these patients TPA because they may not all be TODS paralysis. As a matter of fact, one of the more common presentations of stroke in elderly is going to be seizure onset. This has been looked at by several authors, and so it's a little bit hard to pin exactly what percentage of strokes will actually present with seizures. Some authors give as high numbers as 5 to 10%. I don't know if that's necessarily accurate, but one author basically looked at about 10,000 patients who ended up giving IV thrombolytics, and they noted that 1.5% of these patients ended up having strokes. 1.5% ended up having seizures. They later found that a full 1% of these patients actually ended up having strokes, and their presentation was a seizure. So it's not always TOD paralysis. Of note in regards to this patient, they all got TPA, the TPA with non-seizure, the symptomatic intracranial hemorrhage risk with non-seizure patients who had straight up strokes ended up having a 3% risk, a 3.7% risk. And the ones with seizures had about a 5% risk. So it was a non-significant risk, but the point is that you should recognize these and at least consider them, that they may be strokes and not just always seizures. Migraine is another common mimic that you may end up seeing. Typically the patients that do present with this are going to be younger females, just because that's the demographic of most migraine sufferers. Typically, it's considered that the aura is what actually ends up causing hemiparetic and focal findings in migraine. There's a concept of something referred to as cortical spreading depression, where basically you end up having a brief episode of hyperemia that lasts for a couple minutes, and then that is followed by a period of a couple hours of oligemia that can reduce the blood flow to about 70 to 80% of its pre-aura status. This can be a cause of some of the focal deficits that you see with migraineurs, And so it's important to just kind of understand. There are other possibilities that you should probably consider in patients with focal deficits with migraines. Most notably would be a paradoxical emboli, where patients end up having a PFO. You may also want to consider dissections as well too in some of these patients, because they can also end up causing these focal deficits. And remember, sometimes the very medications that we give patients to treat these illnesses with can also end up causing vasospasms that can end up causing these issues down. I'm not going to go into functional disorders or what's referred to as conversion disorders. It's going to be a little bit of a tricky status, and obviously you have to use basically your gestalt and your clinical judgment to make the best decisions possible. So now going through our 4 big questions of what we must know is there a large vessel occlusion? And so that's become essentially, if you're at a comprehensive stroke center, the question is that, is there an LVO? Do these patients need to go for a thrombectomy? So to answer that, we're not going to go straight to angiography. Vascular studies obviously are performed, but I want to take a step back and I want to go to pre-hospital scales and NIH stroke scale scores, which I feel we don't understand enough. So first I want to just kind of discuss a little bit on pre-hospital scales and what they mean to your stroke center. So there are various different kinds. Most notably, people have probably heard of the FAST scale. So for FAST is short for face, arm drip, speech, and T is time. There's other ones as well too. One of the ones that we use here in New York State is a LAMS score, Los Angeles Motor Score, sometimes referred to as a SLAM score. Now, all these scores are going to be very simplified. They're going to be utilized for very, very quick assessment, usually less than 30 seconds or so. And essentially, they're going to have a very, very rudimentary scoring system because they're not meant to be thorough, they're meant to be fast. The LAMS score has been validated, and this is actually what we use right now in regards to triaging patients to comprehensive versus primary stroke centers. You can see the sensitivities and the specificities basically in one of its validation studies. You can also end up seeing the percentage of large vessel occlusions denoted in turquoise or blue, the number of medium vessel occlusions as well too. And obviously, as the score gets higher, the percentage of patients who have a large vessel occlusion increases. Fairly straightforward. In regards to basically how we triage in New York State, your EMS providers will sometimes give you these scores. It's important for you to know these scores because as you see down here at the bottom, LAMS scores of 3 or less will go to the nearest primary stroke center. You see right over here, LAMS scores of greater than 4 or equal to 4 will actually bypass your primary stroke center and they will proceed directly to a comprehensive stroke center. So it's important to understand that your pre-hospital providers are already making assessments on these. Now that doesn't mean that you should preclude that any of these patients have LVOs. Obviously that shouldn't be the case, but it is something for you to understand the system that we have set up for stroke and that it's far kind of, it even extends before the emergency department into the pre-hospital arena. There's other scores as well that people have used to look at, such as this pre-hospital acute severity score, also end up calling a PASS score, and they're going to end up having various questions. You can see right over here that the middle question looks at gaze palsy and deviation. This is the question that has the highest likelihood ratios to end up having an LVO because essentially you're looking for a cortical sign. Again, basically looking at the specificity of some of these scores using various scores with race and PASS and LAMS. The FAST-ED is another score. Again, basically now we're just essentially modifying the initial FAST score for stroke, and then with the E and the D, we're adding on eye deviation and denial or neglect, which essentially is looking for visuospatial issues in the brain. And so in this situation, we're looking for both left-sided lesions and right-sided lesions respectively, because because visual neglect is going to be looking at essentially the right side of the brain in most patients. Again, you're looking at the accuracy in some of these scores, and probably the most important thing that you can note is that even patients who end up having these scores of 0 and 1 can still have a large vessel occlusion. So if you get anything from this, that's probably the most important thing that you should take away from this. So it's not going to substitute for your clinical exam and what should be your NIH stroke scale score. Again, basically looking at some of the sensitivities and specificities of the FAST-ED score. And essentially with most of these, you're going to get into specificities around the 70th to 80th percentile. So there are going to be ones that miss, and obviously you're going to end up playing a balance between sensitivities as you increase these scores. Be fast is another common one, essentially utilized to help catch missed strokes on the initial FAST score. And it's also with the B that usually stands for balance and eyes. And so what that's going to do is, again, that's going to look for more posterior circulation strokes and anterior circulation strokes, because the balance will also look at leg weakness as well. So moving on to that, I really wanted to kind of address our NIH stroke scale, because obviously that's the language that most of us use. If you remember kind of looking at those New York State requirements, having an NIH stroke scale score is a requirement basically when your patients are presenting to you and at 24 hours after you give TPA. So it's important that we know this. It really should be understood that this this NIH stroke scale was devised for clinical research. It's not devised as a bedside test. It's been essentially extrapolated and now begun to be used, and now it's standard to be used at the bedside, but that's never what it was initially devised for. It's 15 points, and obviously greater scores correlate to larger infarctions. It's intended for reproducibility, not necessarily for accuracy. And of note, it's very heavily weighted towards language. There are questions on aphasia and dysarthria. And if you don't understand the difference, remember dysarthria has to do with a weakness in the palate that causes you to slur your speech. Aphasia is essentially affecting the language centers of the brain. But the NIH stroke scale score affects and it tests for language much more than it does for visual spatial neglect. And so it has been studied that patients who will have equivalent stroke volumes on the right or the left will end up having stroke scale scores 4 points higher when the strokes are on the left as versus the right as a manifestation of this score. So there are failings of this score, and you need to understand those. Additionally, most of the studies that were done, including this score, do not include brainstem strokes. As a matter of fact, they were excluded in most of the studies that looked at NIH stroke scales. So remember, this is also going to be a very, very poor assessment of brainstem strokes as well too. So you may end up having stroke scale scores of 1 to 2, for instance, if you have a lateral medullary syndrome, excuse me. In regards to looking at NIH and using that for LVO, the guidelines essentially try to find a sweet spot that they use to end up performing vascular imaging to look for LVO. It's been looked at in several different studies. One author looked at some retrospective reviews, and essentially their determination was that there is no NIH stroke scale sufficient to exclude LVOs. We've tried to use 7, 6, some authors use 10, as a way of optimizing our area under the curve so we can maximize sensitivities and specificities. But remember, even at stroke scale scores of 1 and 2, sometimes even in 0, you may end up having a large vessel occlusion. So you do need to understand that no stroke scale score precludes these LVOs. Moss also looked at one, basically found the same findings, that the NIH stroke scale score is poor to detect large vessel occlusion. This little paragraph right over here, every time I tried to say it, I always screwed it up. But essentially the idea is that stroke scale scores less than 9, or excuse me, less than 10, will still have 55% of the patients may still have an LVO. So it's something that you need to be cautious about when trying to mechanically applying some of the guidelines to some of these patients that you end up seeing walking in the door. So for myself, I'm actually a little bit very, very liberal when it comes to vascular imaging, because obviously missing an LVO can be a catastrophic issue. And it's obviously something that you want to get to sooner rather than later, so you can refer it for thrombectomy or transport upstairs to thrombectomy if you are working at a Thrombectomy-Capable center or higher. So moving on to imaging, I think that there are certain things that we need to use, and there's a certain, that you need to understand, and that there's a certain language that also is going to be demonstrated that I wanted to kind of at least introduce you to so you understand it. Everybody who gets through medical school should probably understand the DensMCA sign. Obviously, it's an inclusion of the M1. Essentially, looking at the basilar, now we're in the posterior circulation. This is essentially what a dense artery sign of the basilar trunk will look like. In terms of a quick caveat, just a very brief note about tip of the basilar syndrome. This is commonly one of the things that ends up causing your classic locked-in syndrome that you read about and you hear about in medical school. And so some patients will present with depressed mental status, alterations in consciousness, and that will be a manifestation of a stroke. So if you do have some of these patients and they're not giving you any other ideas in terms of what they could be, so for instance, sepsis or some other form of encephalopathy, it may be worthwhile to consider the vascular imaging of the brain and of the neck. So moving back to our images, this is essentially looking at a hyperdense dot sign in the M2s, which is another sign of cardioembolic disease, basically hitting into the M2 vessels in the brain. Calcified emboli have a very high preponderance for recurrent strokes, as you can see right over here. A lot of people talk about essentially the insular cortex and the obscuration of the lentiform nucleus as early signs of ischemic injury. We're going to go through some of those, but essentially in this picture right over here, this isn't the greatest image, but this essentially is your insular cortex of this area right over here. And one of our early findings for ischemia is obscuration of that. And so if you kind of look right over here, you begin to see cytotoxic edema, which blurs those lines. And this indeed is an early sign of having a stroke. Additionally, another one is obscuration of the lentiform nucleus, where you essentially are going to end up having a stroke in the basal ganglia, or probably be in one areas where the lenticular striates are supplying. So if you look over here on the patient's left side, you end up seeing caudate, you see lentiform nucleus, and you see the internal capsule. If you look on this side, you don't see those delineations anymore. You see loss of those. And they can be very subtle. Sometimes your radiologist will miss them. So you do need to at least be ready to kind of look for some of these findings. And so based on some of those, I wanted to kind of briefly touch on something called an aspect score. Essentially, in terms of looking at stroke, this is a way to semi-quantitatively identify MCA territory infarcts. The reason why we're focused so much on the MCA territory is in regards to the MCA, that is the branch of the intracranial vessels that is the least angled. So I kind of look at it as analogous to a right lower lobe pneumonia for aspiration. It ends up having the least angle. So that's going to be where clot is going to go to first. And so that's why it's studied more so than most other strokes in the brain. So quite simply, the MCA territory is broken down into 10 different components, and a score of 10 is given to a patient who has completely normal appearing brain on CT scan. However, if any of those 10 components is obscured by cytotoxic edema, swelling, hypodensities, then patients will get 1 point removed from them. 10 is going to be the optimal score, 0 is going to be the worst score. And essentially, aspect scores are going to predict favorable functional outcome, and it's going to basically, and in some ways, people have tried to see if it predicts less symptomatic hemorrhage with intravenous thrombolytics. So kind of looking at essentially how we would grade this, this essentially is how we would first grade this. And I guess before I kind of continue, there is an app that I use called Neuro Toolkit. I think it's probably an important one to kind of have at your bedside. It goes through stroke scale scores. It also goes through aspect scores with you. I think it might be valuable to have. I don't endorse the product, or I don't have financial, I don't have any financial contribution from the product. But anyway, I think it would be useful, especially for first and second year residents who are getting used to managing some of these patients. Nonetheless, back to aspect scores. One cut is typically taken at the level of the basal ganglia, and you can see how we've broken this up into caudate, internal capsule, lentiform nucleus, insula, and then essentially some of your lower areas of your cortex, referred to as 1, 2, and 3. And then if you move up to the lateral ventricles, just a little bit superior, you end up seeing M4, M5, and 6. Those are 10 sections, and if one of those sections ends up being hypodense, the patient gets 1 point subtracted from their initial 10 to end up basically formulating an aspect score, which will give you a semi-quantitative response or a semi-quantitative evaluation of these MCA territory strokes. This has actually been looked at. So Steve Levine, who worked on the original NIHSS trial, basically got together with some investigators, and they actually applied aspect scores to each CT scan of the original NIHSS patients, and they tried to actually see if you could correlate significance for bleeding on these patients with intravenous thrombolytics and who did well and who did bad. However, they didn't find any significance with increased intracranial hemorrhage with these strokes. What they did found that there was a trend toward increased symptomatic intracranial hemorrhage when you end up giving patients who have lower aspect scores, most notably the 0 to 2 range, intravenous thrombolytics, but their findings were that in the first 3 hours, you should not use this as a way of withholding thrombolytics in these patients. Furthermore, one of the reasons why it is that way is because, as you can kind of see right over here, higher aspect scores correlate to smaller strokes and vice versa. So going into thrombolytics just very quickly, this is from the guidelines. Essentially, you should all know this by now. Patients coming in with acute findings, less than 3 hours, get thrombolytics. So level 1A recommendation, we'll move on. This is widely based on the original NIHSS trial, and essentially kind of going to the contraindications of the original NIHSS trial. This is from 1995. It actually hasn't changed that much. Which I find to be pretty impressive that after 25 years, we haven't really changed this that much. So either they were forward thinking or we're behind right now, or maybe a combination of the two. But there are two changes that I think that you need to kind of understand. Major surgery within 14 days is now a relative contraindication, not an absolute. And I basically already said seizures are now a relative contraindication with given TBA. This is our current contraindication in regards to giving TPA. The biggest things that I think that you should be asking when you initially see these patients is, number one, what is their last known well? Not when the symptoms occurred, what was the last time that they were known well? Because sometimes you may not get symptom onset. The next thing that I think everybody needs to be asked, especially in this day and age, is are you on any anticoagulation? And have you had any intracranial hemorrhage? That's usually how I start with these patients. That's basically all I want to know in addition to their physical exam. And in many situations, that may be all you have in regards to pushing TPA or not. Now, 3 to 4.5 hours in regards to giving intravenous thrombolytics is a little more nuanced. I want to make sure that it's clear to everyone over here that patients who end up basically presenting within the first 0 to 3 hours do not require any consent to give TPA. You have to give verbal consent only. They do not require any written consent within the first 3 hours. Patients within 3 to 4.5 hours on both sides of the street, as a matter of policy, are required to give written consent for TPA. And I just want to make sure that that's crystal clear to everybody involved and everybody who's listening right now. The reason why we get the 3 to 4.5 hour rule is essentially from the ECAS-3 trial in 2008. So this is the third European trial, and essentially, interestingly, looking back at this trial, what they actually tried to do was extend the window. The rationale is that ECAS-1 and ECAS-2 initially were looking at patients between 0 and 6 hours, and no good results were being found in regards to giving TPA. Namely, we were giving these patients more bleeds, and it wasn't worth it overall, we felt, in regards to continue to give TPA. This was initially this study started with a extended window to 4 hours. However, the authors noted that they didn't have enough patients basically in that 3 to 4 hour window, so they extended it to 4.5. However, looking at the breakdown, it is equivalent in the final numbers in patients that presented between 3.5 to 4, and 4 to 4.5 hours. So it's not front or back loaded in regards to the distribution of patients presenting with their symptoms. And essentially, in regards to modified Rankin score, there was a significant improvement of about 7%. In regards to your exclusion criteria, octogenarians were excluded, and also one of your notable exclusions, patients with diabetes and prior stroke. However, of note, there has been an indication creep from this initial trial with 0 to 4.5 hours 12 years ago in regards to patients that we will give TPA to in this extended window. So it's important to understand that. The other thing is that looking at essentially the symptomatic ICH rate, it's higher. And so it's important for you to understand, and it's really important for you to interpret that patients who end up having any kind of intracranial hemorrhage, that is not what we're looking for when we see basically harm in these patients. We're looking at symptomatic intracranial hemorrhage. And it should also be understood that that is defined in various ways in regards to looking at the studies. The initial NIHSS trial basically looked at patients who deteriorated, which is a very subjective term, or suspicion of bleed on CT scan as an indication of symptomatic ICH. The initial ECAS-2 trial basically looked at something similar and used very, very subjective terminology to determine symptomatic ICH. The ECAS-3 trial basically used a stroke scale score of basically worsened by 4 points and any intracerebral hemorrhage. And there is something called the Heidelberg score, or the Heidelberg scale, which essentially tries to assess intracerebral hemorrhage. And I think it's important to kind of go through, it's beyond the scope of what we're talking about now, to just understand that some bleeds are expected in stroke, and some bleeds will, some strokes will bleed regardless of what you end up doing to them. So I think it is important to understand exactly what we're looking for before we kind of look at basically symptomatic ICH. Nonetheless, this trial did have a higher percentage of symptomatic ICH by both the NIHSS definition and the ECAS-3 definition, but note the differences over there in regards to kind of what we're looking at. And as you change the definitions, you can change essentially how we're regarding symptomatic ICH, and that's the reason why this is listed in this trial. Looking at essentially basically how the patients did, obviously, like I just said, they improved a little bit in terms of the patients who had modified Rankins of 0 to 1. Now, moving on, back to mimics. Some people have a little bit of a concern in terms of, should I give it? I don't know if it's, should I give intravenous thrombolytics? I don't know if these patients end up having stroke mimic. I'm a little unclear. We talked about one trial, and in regards to giving you more data, there is another trial that was looked at last year by Ali Ahmed, where they evaluated about 75,000 patients who ended up getting intravenous thrombolytics. They found a 3.5% symptomatic intracerebral hemorrhage rate with all comers, and essentially with patients who end up having some of the mimics, their breakdown was essentially about this. Most patients who ended up having stroke mimics were migraines, about 10% were seizures, functional disorders, or conversion was about 10%. And so essentially, kind of looking at those numbers, there's about 3.5% symptomatic intracerebral hemorrhage rate with patients who had a bona fide ischemic stroke that was later determined by MRI findings, and patients who ended up having symptomatic ICH who had stroke mimics were about 0.5%, basically less than 1%, which is similar to what the ICH rate was, if I remember correctly, for IV thrombolytics and MI. Now, a little bit of clinical management in regards to these patients. I have seen various strategies with this, and I'd like to kind of give you mine because I think that it might kind of assist us if we're trying to manage blood pressure control right before giving patients TPA. Many times we see patients 2 hours from symptom onset or from last known well that we're ready to give TPA to, and they have blood pressure issues. I see lots of different wide variation. Nicardipine first, 20 milligrams of labetalol first. I see a little bit of everything. What I would probably advise you to do is order nicardipine on every single one of these patients because you need tight blood pressure control. However, setting up the nicardipine drip during this time in a time-effective manner is going to be difficult. Therefore, I would probably advise you to use 1 10 milligram IV push prior to this. The reason why 10 milligrams and not 20, which a lot of us want to do, is that you don't want to cause these patients to become hypoperfused. Start your nicardipine at 5, go up to approximately 10 or so, and you can go up 2.5 every 5 minutes, and you can see if their blood pressure has been managed. If you don't have control, give another 10 of labetalol, and you can also continue to go up with your nicardipine drip. If you're still having issues after that, you may want to consider another labetalol. You may want to consider another 10 push of labetalol, but typically that will control pretty much almost every patient that I've ever seen with a stroke in terms of if they were eligible for IV thrombolytics. So I wanted to just show this slide in regards to essentially what we hope to achieve with intravenous thrombolytics, right? We want recanalization. That's essentially what we're looking for. But remember, the intracranial vessels are different size. The M3 and 4 vessels, which are tinier, are going to end up having less diameter than the internal carotid artery. So you're going to have different recanalization rates with some of these different vessels if they are affected. So for instance, if you have an occlusion of the internal carotid artery, you may have recanalization rates of around 20 to 30%. Some authors say less. That's usually about the average. If you have a cardioembolic event in the M1, you may have a 40, 50, the 60% recanalization rate. So it's important to understand that even though you may get recanalization because you are looking for forward flow, it's not going to be complete in all patients. And so it is important to understand that it doesn't dissolve the clot immediately everywhere, as we probably all know. And so that basically is our segue into endovascular treatment. So in regards to basically, let's see if this works. In regards to endovascular treatment, there's supposed to be a video right over here, but in regards to current endovascular treatment, it's not working. Essentially what we do right now is, and around 2014-15, there were a host of papers that came out that showed the benefits of endovascular treatment, whereas the other ones had failed. Essentially, and unfortunately, I'm sorry, I'll give you the link to this if you'd like to. Oh, here we go. Basically what ends up happening is your interventional neurosurgeon is going to run a wire through the clot, and this is essentially your guide wire. They will then run the catheter through this as well, and then that will follow with what's called a stent or a stent retriever. And this is essentially the idea that we're doing. What will end up happening is that this stent retriever will be expanded within the clot itself, and in that way, we will be able to aspirate the clot. And that has basically been very effective. And this was essentially started around 2014 with several trials that came out. And this is essentially now our standard when we perform endovascular treatment. So you can see this, the stent's been expanded into the clot. You're going to end up having basically the aspiration catheter. The clot's going to be aspirated into the catheter. And there we go. And this is the concept behind stent retrieval. So there were several trials that came out in the early 2010s, 13, 14, 15. It was all started by one trial, Mr. Clean. And essentially what they used is they looked at basically proximal lesions, M1s, M2s, A1s, A2s, and they included patients who had an NIH stroke scale score of 2. Again, there was very little limitation, so they expected even patients with very low stroke scale scores to have large vessel occlusions. 80% of them used stents, and essentially the number of patients that they ended up finding with modified Rankin scores of good outcome, it was definitely significantly higher than patients who didn't get endovascular treatment, who just got TPA, because of the reasons that we were talking about before, in that sometimes, in many times, TPA is not sufficient to recanalize your vessel. That's the reason why we use most of these strategies for our proximal vessels, because it's got a much less successful rates for recanalization for intravenous thrombolytics. You can see basically here the modified Rankin scores in terms of the Mr. Clean trial. Moving on basically to the ESCAPE trial was another trial that came out at the same time around 2014, 2015. It was cut short because of the success of the Mr. Clean trial, but again, they were using the same idea. Basically, patients who end up having a proximal vessel stroke or a large vessel occlusion, again in the M1, M2, A1, A2 vessels. They had better mortality rates. They had better modified Rankins after 90 days. And virtually every demographic, basically performing stent retrieval was better. The Swift Prime trial was another trial that came out about that time, 2014, 2015. Again, this was also terminated early because of the success of Mr. Clean. And again, we ended up having, we ended up having a much higher number of patients who had better functional outcomes at 90 days than in just IVTPA. So moving on to our very last segment, we were talking about basically, is there a hemorrhage or a mimic? Is the LVO occluded? Is there any kind of irreversible brain injury? And is there a penumbra? And that's what we're going to talk about right now. So basically, is there a penumbra present? And that's our last and final thing that we're going to talk about in regards to approaching our stroke codes. And so that's going to introduce the concept of CT perfusion scanning. So this is for the physics people in regards to radiologists, where we're looking at essentially how we're going to assess our CT perfusion scan. But in reality, we have this technology at Downstate. We do not have this at Kings County. But this is the rationale for basically having your patients within 24 hours have stroke codes. roads, because these patients who have LVOs and they end up presenting within 24 hours are now candidates. And in this situation, we've now begun to shift away from using time as our marker of ischemia and, as a marker of infarction, to begin to use perfusion and collaterals as a marker of ischemia and infarction. And so there's a lot of different numbers that you're going to see here, but what I want you to do is I just want you to understand two values. That's it. Cerebral blood flow and cerebral blood volume. And I'm going to show you two different setups that they ended up having. Cerebral blood volume is going to give you a marker of infarcted tissue. Cerebral blood flow is going to be a marker of ischemic tissue. And so essentially that mismatch between those two is going to end up basically looking at your penumbra. So in patients who end up having infarcted tissue, essentially your cerebral blood volume is going to go down. In patients who end up having essentially just ischemic tissue, your cerebral blood volume will be the same, it might even be higher. Now your cerebral blood flow is going to be depressed in either way, and this is what it's going to look topographically. So you're going to see some of these images over at Downstate. This essentially is the OLEA software. There's also software called Rapid that we had at Downstate, but I wanted to show you this because this is one of the easiest ones. This is a 55-year-old person who has right hemiparesis. So obviously we're looking at the left side of the brain. So as you see right over here, basically you don't need to look at time to peak, you don't need to look at mean transit time, but as you see right over here, look at cerebral blood volume. You don't necessarily see any dead tissue yet. You see equivalent tissue based on your color scheme that's to the right of the CT scan. Now, if you look at the cerebral blood flow, which is giving you an idea about obviously blood flow to the tissue, you see a mismatch. And you see a relatively large mismatch that corresponds to the MCA territory. This essentially is a large ischemic penumbra, and this is what we're looking for, and this is why we've extended this window to 24 hours, so these patients can have mechanical thrombectomies. Now, if you go down here to the bottom left-hand corner, you see that there's obviously a lesion in the M1, and that's what's causing the deficit. And this essentially is why you're going to transfer these patients to a comprehensive or thrombectomy-capable sort of center. Now, looking at it from basically a patient who had a poor prognosis. If we're looking at a 73-year-old with left hemiparesis, again, we're looking at cerebral blood volume first. Now, you actually end up seeing a patient who has basically infarction of the parietofrontal area. You look at the cerebral blood flow and you end up seeing the corresponding ischemia or the corresponding infarction. And so in this patient, there is no mismatch. Therefore, this is a patient that has already had dead tissue. Therefore, going forward with mechanical thrombectomies at this time is futile. And this is the way that we determine basically if these patients are going to be referred for mechanical thrombectomies outside the initial 6-hour window. What we have right here at Downstate, and what you should at least understand a little bit, is the Rapid software. And so it's a little bit different over here, but essentially, to make it very kind of easy, pink is dead brain, green is ischemic brain. And based on this, we end up having a mismatch, or that's a mismatch is what you're looking for. So you can see down here in the bottom of this image, 46 millimeters, basically infarcted area, 111 areas of ischemic area. And so that potentially is salvageable tissue. And so that's the reason why we will either decide to transfer patients or not based on those numbers. Now, in regards to our Rapid criteria, there's essentially, this is from the Diffuse 3 study, and this kind of makes it a little bit complicated, but just remember, if the ratio is about 2 or higher, that's an indication. If you have a small core, less than 50 millimeters, 70 millimeters, that can be an indication. And if you have delayed volume, basically less than 100 milliliters, that can be an indication. And so moving forward with this, I have 2 more slides and then we'll move on. Essentially, I wanted to show you basically the concept of the DAWN trial. And so this was always very difficult for me to understand. And this trial basically looks at utilizing CT perfusions, performing thrombectomies up to 24 hours. And this was their inclusion criteria. And initially, this was very, very confusing for me to understand. You have this very complicated scheme. But what I want you to take from this is essentially, you're taking very small infarct volumes with very high NIH stroke scale scores. So for instance, right over here in category C, you have a relatively small infarct of basically 30 to 50 milliliters, but you have an NIH stroke scale score of 20. And the idea of essentially that discordance between stroke scale score, or really just basically deficits that your patient has, is because of the ischemic penumbra that you potentially can reverse. And that's the reason, and that's the inclusion criteria for our DAWN trial, which initially set the stage for us to move on into basically performing these patients, performing thrombectomies on these patients up to 24 hours. And so in regards to basically recanalization rates, much higher, basically functional independence at 90 days, much higher in this in the DAWN trial, and basically patients who ended up getting thrombectomy. Of note, they use something called the utility weighted modified Rankin score, so I think it's important for you to understand that. But in the essence of time, we're just going to kind of move on past that very quickly. And then obviously you can see the patients who ended up having basically modified Rankin scores at 90 days in comparison to those who did not get thrombectomy. The extended window in terms of the diffuse 3 trial, if you look essentially right here, it's exactly those guidelines and this criteria that I gave you in regards to performing thrombectomy. And so again, patients who end up having functional dependence, much higher in those who had basically thrombectomy than those who didn't. And so that's it in regards to kind of how our approach to our stroke code is going to be. I just wanted to kind of reiterate that you should be having a systematic way of approaching it. This is one way. It doesn't matter which way you do. And if you don't have one, use mine until you get your own. But essentially you should be asking, is there a mimic? Is there an LVO that's included? Is the brain permanently injured? And do you have the number? And that's the questions that you should be asking when you're approaching these patients. That's it. Any questions?
Yeah, there's a few on Zoom. One question was, is there a plan to get seizure perfusion at county? And also, like, what's the process that they're doing because there's not one?
That's so that's over my head. We do have a interventional neuroradiologist. His name is Donnie Bell. I'm sure many of you have heard of him. And so there is a trial called the MR Witness trial. And essentially what that trial does simple question, no. We don't have, right now, CT perfusion is not planned, at least at this period of time. It's being worked on. But you'll probably know if you've dealt with Donnie Bell that a lot of times he asks for MRI. And you're probably like, why does he ask for MRI? There is a trial called the MR Witness trial where patients were actually, where essentially this was a non-inferiority trial to actually look at extending TPA up to 9, 12 hours out, intravenous thrombolytics. And the rationale for this is that patients who end up having DWI positive MRI lesions, so essentially diffuse restriction, that they're positive, but are flare negative. And so if you remember, flare is a T2 study that basically patients look up. And the idea is that if essentially you haven't seen flare changes yet, but you already have DWI, that's essentially another way to assess perfusion. So if you've noticed sometimes when we have a potential patient who could go to the CAT scan, who could go to neurointerventional, but they're like, get an MRI. And a lot of times you're like, well, why? The brain is already dead. The reason is for that. We're looking for discrepancies of the DWI into the flare sequence. And that's one of the reasons why we do the way that we do. But to answer the question, at this point in time, no, we're working on it. We'll see what happens. But downstate does have it.
Okay. What is the logistics of the CT perfusion scan? Like, how long does it take?
It's very quick.
Is it just a scan with like software? Is it a software scan?
It's a scan with software. Essentially what ends up happening is that the patients go into the CT scanner, and there are limitations. Lacuna strokes are limitations. There are some limitations, but again, that's outside the scope right over here. Essentially, it will probably add on about 5 minutes to your CT scan, to your CTA. So for instance, if you go to a comprehensive stroke center where we're just CTAing and CTPing everybody, essentially they get their initial CT head, which obviously you all know how, obviously we all know how long that takes. And then we end up going first the CT perfusion, which again, a few minutes, maybe up to 5, and then the CTA, which takes 30 seconds or so. So we end up basically going forward with that, and that's about it. But what it does is it actually ends up giving bursts of contrast. And essentially what you'll see if you actually see the patient, they're going back and forth. forward and back, forward and back, forward and back within the CT scanner to end up looking at those vessels as we're consistently giving contrast in a way to try to make those assessments that I was talking about in this, looking at the real software and the rapid and the ELIAS software.
Dr. Valesky?
Yes.
Hi, good morning. Thank you for your excellent lecture. Quick question. The DAWN and DIFFUSE trial that we used to provide evidence for thrombectomy up to 16 or 24 hours, they used really sophisticated, not commercially available softwares to determine the existence of the penumbra and making decision whether somebody needs thrombectomy or not. These they didn't use CT perfusion scans or MRIs for their studies. Are you aware of any studies to see if the findings are being reproduced by using poor man's methods like CT perfusions or CTAs, or we are extrapolating the data that was based on sophisticated softwares to what most stroke centers have?
We are extrapolating. I don't know of any studies like that. And like I was basically referring to Sophia's question, there are other ways in which that we are forced to do it at Kings County, such as the way as written about in the MR witness trial, where we're using discrepancies between DWI and T2 flare. But no, I don't have any studies that we basically kind of go ahead and have used basically our commercial software, such as the Rapid and the ELIA software. I'm sure we're going to end up having one coming out soon. What I would say though is, working at a comprehensive stroke center over at MIMO for a couple of weeks, it is very, very impressive seeing some of these patients. I remember essentially when we ended up having a gentleman named Mangala, if I remember correctly, over here at SUNY Downstate. And it seemed like every patient that went for neurointervention, essentially they ended up a mess. And it seemed like that was just the general consensus at SUNY Downstate. Obviously, part of the things that go into this are the number of patients. And so I think that you can probably take that with just about any disease course, that if you end up repeating the same thing over and over, you get very efficient at the process. And so I think one of the issues that we end up having is that these mechanical thrombectomies and kind of applying the DAWN and the DIFFUSE 3 should optimally be done at comprehensive stroke centers that end up having just really, really high numbers and big volumes of patients that are coming in for mechanical thrombectomy. But in regards to the evidence and the question that you're asking, no, I don't know of anything that's using the software that we have right now.
Thank you.
There was one last question in the chat, which I'm sure you would have figured to be brought up, but the New England Journal paper about the TPA plus thrombectomy.
Okay.
Or not, the non-inferior.
So the DIRECT-MT trial. So this is a trial that came out basically about 3 months ago, I believe in May, and I'd be more than happy to have a journal club at my house if you guys want to discuss this beforehand. This was a Chinese trial. I can't remember exactly how many numbers was, maybe at least a few hundred. Different setup than in the United States in regards to basically just kind of the healthcare system. There's actually a section where it talks about how the patient's families themselves are having to deal with the financial situation of getting TPA and the thrombectomy. However, and essentially what they did was they looked at patients who ended up getting mechanical thrombectomy, and they compared that to patients alone without intravenous thrombolytics. And they compared this to patients who basically got both thrombolytics and mechanical thrombectomy. Now, there's a couple things that I think that you need to look at if you are trying to apply the DIRECT-MT trial to your patients. So a couple different things. Number one, the patients, the mean time in terms of randomization, if I remember correctly, in the DIRECT-MT trial was less than 180 minutes. That's the time in which they were randomized. So they were not only basically kind of getting started on either, not only being evaluated, seen, they essentially had their symptoms, was assessed by a physician, had their CT scan, and were randomized to TPA versus not TPA, and both groups got thrombectomy within 3 hours. Number two, All the patients, or the mean time in terms of groin stick, was 30 minutes after that. So these patients were getting their thrombectomies within, or at least they were being initiated within 3.5 hours. Now, in that trial, and I can't remember the exact numbers, but if I remember correctly, it's about 85% of the patients had the TPA running as the thrombectomy was performed. So what that means is that these patients were basically presenting to a thrombectomy-capable stroke center, or whatever China's version of that is. 85% of the patients. So they actually make a reference to this in the discussion section of that study, and they do say that this is not necessarily something that you can replicate in patients who need to be initially evaluated at one hospital and transferred to another hospital. So at this period of time, standard of care is still to give TPA. Also, if you end up having an outcome and you've refrained from getting TPA and you've transferred a patient, because remember, at SUNY Downstate, you would be transferring. Now, basically at Kings County, it may be a little different because we have thrombectomy-capable stroke center. But since most of these patients were actually started the thrombectomy at the same place that they got the TPA, I think you really need to be careful and kind of avoiding kind of extrapolating some of this to our situation at Downstate. Kings County may be another situation, and I think it could be worth discussing this with your stroke neurologist, and especially if they're ready to go. But if you do have a situation where your patients are waiting, so for instance, you don't have CT perfusion over at Kings County, if you're sitting around and you're sitting on these patients for 2-3 hours so they can get the MRI, it might not be the optimal strategy for what we have at these two hospitals. And so that's my commentary.
Hey, this is Willis over at County. Just first of all, thanks, Dr. Valesky. Quick comment, this is extremely important when you guys go work in other places where you're not lucky enough to have neurology coming down to every stroke code or a neuroradiologist reading your scans. You really need to know the contraindications for TPA, and then you need to document them when you don't give TPA. You will get dinged for this, your hospital will get dinged for this, and you won't be a stroke center anymore. A quick question, Dr. Valesky, given all the data you present, are you advocating for a reflex CTA with every CT for these patients?
I would err on the side of getting a CTA versus not. I think that there are some situations where you can definitely avoid it, but I know that I've discussed, when I was kind of on the stroke service and I've seen some, and I've been talking with some of the attendings, I know that there was somewhat of an annoyance with our current setup, especially over at the county, where we obtain a CT head, we come back, we evaluate the patient, and then neurology asks for a CTA of the head. And I know that sometimes it can seem a little redundant and extraneous in terms of this. I think it depends on your clinical exam, but if there was any concern, I would probably err on the side of going ahead and getting the CTA, because obviously if you have little area, because obviously if you miss an LVO, that's going to be catastrophic for one of these patients, and we have the systems in place to transfer these patients or to perform the thrombectomies ourselves. So in a perfect scenario where obviously it does not look like you end up having an LVO, sure, I don't think you need one, and you can basically just get the vascular imaging when you get your MR. But if there's anything out of the ordinary that potentially this patient could have an LVO, I would err on the side of just going ahead and getting the CTA. I think the risks do not outweigh the benefits in that scenario.
Great, thank you. Thanks, Dr. Valesky. Appreciate it.